Hello students, we'll discuss today an interesting topic, rather very academic also, that is Pandora's box, abdomen. It's quite common to consider that one because you know that when you open the abdomen, you think something and finally it is something else, and eventually may not be anything. So that is the very typical true nature of the abdomen. That is, in spite of all available investigations, when you open, there is a lot of surprise within that. That is why it is called as a Pandora's box. So it's a good topic to discuss in detail why it is so, what are the reasons, how we will approach these things about this Pandora's box. Rather, it is called as magic box. So Pandora's box is actually in a Greek legend or Greek mythology. See, there was once history long ago. There were only men. There were no female. So God, as mighty God, Jesus has created a woman out of clay and named her as a Pandora. See that? That is how it's a name of a woman, first woman in the Greek mythology. He also created a husband for Pandora and named him as a Epimetheus. And wedding has happened, and God has given the locked box, and everybody thought this box was a good gift as a good gesture by the God. But God has put a claw in that must never open this box. This box has given, God has told don't open it. So naturally, when somebody says don't do it, there will be a lot of curiosity to that. Same thing happened here. Pandora become very curious and opened up the box. Now, when she opened the box, many bad things came flying out: diseases, evil emotions, negative thoughts, actions. All those negative things has come out, and whatever God has, Jesus has stored all evils in the box. But at the very bottom of the box, there was hope. She closed the box quickly as she could, but it was too late. All evil things has come out of the box, and this is what this Pandora's box means. Pandora is a female's name in a Greek mythology, and box given by the god as a wedding gift, which was opened, and it was containing evils and hopes. So evils has come out, hope also was there. So that is what exactly, when you compare to the abdomen, we don't know what is inside, whether it's a good thing or a bad thing. So that's why it is a very good comparison to Pandora's box. So there is a meaning. Finally, it is the abdomen, how it behaves to a surgeon. Actually, it reflects like that. So box is a metaphor for something that brings about great troubles or misfortune, but also holds hope. So there will be some hope when you open the abdomen. There may be a lot of problems, maybe malignancy, maybe obstruction, maybe peritonitis, maybe perforation, maybe growth, and so on. But finally, you do something, you will have a cure. So hope is there. So there are problems, but there is a hope behind. So that is the exact meaning of this one of Pandora's box actually. And symbolically, this box represents the curiosity and desire for knowledge that can lead to both negative consequences and positive outcomes. There will be negative consequences, there will be positive outcomes. Same thing happens in the abdomen. There are a lot of problems, but eventually, by your good work, surgical skill, surgical principles, outcome will be better. That is positive outcome. That is the exact meaning of comparison of abdomen to Pandora's box. Now we will discuss how this Pandora's box, abdomen, behaves like. So usually called upon because presence of various organs and complex mechanism, complex physiology in the abdomen. So many organs: liver, spleen, GI, kidney, colon, appendix, retroperitoneum. So many organs are there. That's why it has become. So why abdomen is Pandora's box? One never knows what will come out of it when you open the box. When we expect one thing, something, many times unexpected things comes out. We expect one thing, nothing comes out. You may think everything is okay, but things will be very bad. You may think everything is bad, but things will be good. So it is, we are not very clear of exactly, in spite of all your assessment of the patient. That is why it is rightly called as Pandora's box, abdomen. This is what exactly Pandora is opening the box here. So example I will give my own patient. Patient has come with a mass here abdomen with severe pain. So we thought, we did all investigation, CT, everything. They said mass in the right fossa. Could be inflammatory mass, could be malignancy. So we opened accordingly. So when we opened, we found a lesion like this. When we still further opened, it was a gangrenous omentum. We traced the gangrenous was going down, and finally it reached down, and it was a adherent to the inguinal hernial sac, but there was no impulse. This mass in the radial fossa, inguinal region clinically was normal. Even CT told nothing about the hernia. So we thought either inflammatory burst appendix or inflammatory pathology or malignancy, and finally it is the gangrenous omentum in the hernia presented as a mass in the abdomen. So that is what exactly. So actually it is hernia. See, opened like this, then finally opened hernia area also, did hernia surgery, also did omental resection also with the two incisions, parallel incisions. So that is really Pandora's box example. And another one, blunt trauma patient came. We thought hemoperitoneum. CT they told hemoperitoneum. When you opened, you can see the dark bowel here, gangrenous bowel. Because trauma, it was a mesenteric tear completely, and bowel has completely grown and gangrenous, and we did resection anastomosis. And again, patient has come with the discharging sinus post laparoscopy. So we explored it after CT, everything. They are not sure what exactly it is. Even blood evaluation, nothing has come out. Everything was looking normal. And eventually, when you opened, there was a tuberculous omentum here, adherent to the bowel. We did resection, came out as a tuberculosis. So these are the things which can happen. We are not sure, but finally, on opening, we know what exactly it is, because in spite of all investigations, could not identify the cause. But finally, after opening the abdomen, we could make out what exactly it is, what exactly caused for sinus. So again, same thing, hypogastric mass, tender mass was there, and when you opened, it was appendicular mass, and finally we did resection, came out as appendicular carcinoma, adenocarcinoma of the appendix, but presenting as a mass, which has perforated from a mass, not in the radial fossa, in the hypogastric region. So this is the mass actually here, and finally it was the appendicular mass, and we did resection, which was adenocarcinoma. So large nodular mass in the liver, mass in the abdomen actually. So when you opened, it was multiple studded nodules. We thought just ascites, CT was not sure. So opened and saw that studded ascites with the malignancy some place, occult areas. So this is the different examples of all these Pandora's box. Now we will discuss about how exactly go about with this patient. That is most important thing which you have to learn. See, acute abdomen is not acute abdomen, not that easy, not simple. It is not simple. Remember, abdomen is not that acute for surgeons. Remember, it is not acute. It's always pain will be there. What is it? It is sudden, severe, often spontaneous, progressive pain with worsening of the symptoms in 24 hours. That's the definition of the acute abdomen. Pandora's box, of course, and everything covers in Pandora's box. But as a component of that, I am discussing acute abdomen because it is more often truthful in acute abdomen, because you won't be knowing what exactly inside. That's why I'm just discussing acute abdomen as a part of it. Of course, other things also will be discussed. So causes of acute abdomen, I'm not going to detail it. Intestinal causes, so many things are there. Appendicitis, mesenteric and mecal diverticulitis, perforated peptic ulcer, duodenal ulcer or gastric ulcer, diverticulitis, intestinal obstruction, triangulated hernia, everything comes into the picture. So proper clinical examination, suspecting the things, where exactly is the pain and how they present with, and eventually imaging and imagination and biochemical assessment. Eventually we will have a conclusion. Finally, after opening the abdomen or doing laparoscopy, you will have the proper idea of what exactly is the cause. So hepatobiliary, again, biliary colic, cholecystitis, cholangitis, pancreatitis, hepatitis, everything present as a abdomen pain. Ruptured abdominal aortic aneurysm, acute mesenteric ischemia, ischemic colitis. Urological causes also, renal colic is so common, ureteric stone. They present with that. Testicular torsion, if you don't examine the testis, scrotum, you may miss it and they will have acute abdomen. Sometimes undescended testis, so they will have torsion, so scrotum will be empty, they will have presentation acute abdomen. So unless you have a proper thinking, you may miss it because torsion immediately would address, otherwise it will go for gangrene. And gynecologic causes in females, ectopic pregnancy, twisted ovarian cyst, self-angiitis, endometriosis, mid-cycle pain. All those things are the other different causes other than usual causes specific to females which you have to think of. Of course, medical causes which makes acute abdomen. So the things pneumonia, lobar pneumonia, subpulmonic pneumonia can cause diaphragmatic pain, upper abdomen pain, sickle cell crisis, porphyria. Myocardial infarction mimics gallstone, gastritis very common. Cardiac patient present as a gastritis, take treatment for gastritis, sometimes undergo gastroscopy, but you will miss the bus completely because it is a myocardial infarction. So I had a patient came with the features of cholecystitis, thinking that pain of dense gallstones, because patient had ultrasound, which he said that he had got gallstones. But when I examined, his BP was, his hypotensive, tachycardia was there, he said he had sweating, then did an ECG, it was acute myocardial infarction. He had gallstones, but his pain at that point of time was not due to gallstone, it was due to MI. So immediately referred to cardiology, they did timely angioplasty and angioplasty to save the life of the patient. So think these conditions, especially the upper abdomen pain, myocardial infarction, may come to a surgeon, and eventually if you don't remember these 2 days ECG, you may miss the diagnosis and miss the patient also because in acute cardiac status. And most can be diagnosed clinically. Remember, it's a clinical intuition for these patients. Most of the time we'll have thinking process, analysis, repeatedly seeing the patient. It comes a clinical touch. See the patient, you will have an idea what exactly probabilities. Think all those possibilities, then come into conclusion. These are the things possible. Require accurate and focused history taking. History taking is important. Need meticulous, rational physical examination. Appropriate special investigations, of course, that will support you. But clinical history, examination, then imaging. Without history and examination, without examining the patient, you can't give a conclusion by looking at the report. There's a point which is very, very important, especially it is important in the current era because most of the time patient sends ultrasound, CT report and says, give opinion. Unless you examine a patient, don't give a final opinion because you need to examine the patient clinically. Tell them, it's probably this one, but I have to examine the patient and then only I'll give a proper final conclusion about what exactly patient is having. There is a point which you have to remember. It is not right, it is inappropriate to give a opinion without examining a patient based on just evaluation, imaging and biochemical features. And so history taking, patient perception of symptoms, what symptoms they are having, patient description of symptoms, so how they describe, and physical perception. You examine and take what exactly patient is having, that is important. And physical interpretation is also important. So the symptoms, examination, you should know how to interpret. That is analysis, clinical analysis is important. Then eventually you decide what investigations you want to do, what imaging you want to do, how you synthesize the final clinical diagnosis and make a decision how to manage a patient, how to treat a patient. So everything is important. This in ladder is very, very important to approach all these Pandora's box. Otherwise, if you miss these things, then you will have always problem. So decision making, everything is important. So without examining a patient, don't do these things. So all this history is important. What is most important in the abdomen condition, especially in acute conditions, is pain, pain, pain. So all these things about pain you should know. Onset, radiation, site of onset, type, progression, severity, duration. Briefly we'll discuss one by one. So site of pain, so all these things I'm not going to detail it. It marks at biliary colic here, renal colic comes here, cholecystitis here, and central abdomen pain, appendicitis in the right left fossa, uretery colic, colon pain, testicular pain. Site of pain is important. So we'll have the idea probably which organ is affected, probably what is the pathology. So site is important. Upper abdomen pain, so maybe peptic ulcer or gastric ulcer, maybe cholecystitis or cholangitis, maybe pancreatitis which radiates the back, that's important. maybe early appendicitis, hepatitis, liver abscess, or extraabdominal causes, pleurisy, lobar pneumonia, pneumothorax, pericarditis. I said myocardial infarction. It is not uncommon. You will miss entire episode. That is the important thing. Remember, especially in the upper abdomen, especially again, whoever aged plus 50, above 50, sudden episode of this pain. Think of MI, mimics acute upper abdomen. Pyelonephritis and renal colic. Renal colic also mimics, remember. Pyelonephritis also mimics abdomen condition. So central abdomen pain, again same, early appendicitis, bowel obstruction, strangulation, in the around the umbilicus, it is here in this area. Gastroenteritis, mesenteric emboli, thrombosis, mesenteric ischemia basically, descending aortic aneurysm, mesenteric adenitis, sigmoid aortic, everything covers in the central abdomen, this area. So whatever the organ there, mainly bowel pathology, pancreatic pathology comes in the, and retroperitoneal pathology, retroperitoneum, whatever the conditions may mimic that. And lower abdomen pain here, especially in the pelvic conditions, in female, ovary, uterus, ectopic pregnancy, bladder, or sigmoid colon. Appendix also might sometimes present like that. Ureteric stones in the lower part, urinary stones. So many conditions may mimic that. Colonic gangrene obstruction, appendicitis, mesenteric adenitis, diverticulitis, rupture tubo-ovarian mass in female, tubo-ovarian torsions, ectopic gestation. All these conditions may mimic pain in the lower, in this area, pelvic area, you have to remember. So onset of pain is important, maybe sudden onset, maybe gradual onset. So sudden onset pains, all those are acute conditions. Duodenal ulcer perforation, gastric ulcer perforation, ruptured aortic aneurysm, mesenteric infarction, ectopic pregnancy in female, and perforation. Any perforation they present with the sudden onset, maybe having severe pain, maybe radiating, and vomiting will be there, constipation will be there, distension of the abdomen will be there, sometimes fever, toxicity features will be there. So all those things are quite important, but pain will be sudden in onset. That always warns you that something acute condition causes this problem. So gradual onset, gradual pain. So these are the different conditions: gallstones causing cholecystitis, recurrent pancreatitis, and ureteric stone, appendicitis, sometimes incarcerated colon, diverticulitis can cause gradual pain. And types of pain, it may be visceral pain, it may be parietal pain. See that? It's radiating. The visceral pain is, visceral peritoneum will be affected. Parietal pain is parietal peritoneum is affected. In the appendicitis, initially pain is in the visceral area, and eventually it touches the parietal peritoneum, then you'll get the pain in the parietal area. Then rebound tenderness is very typical. So that is the meaning of visceral. Bowel is covered by visceral peritoneum. Then entire abdomen is lined by parietal peritoneum. So initially inflammation occurs in the visceral area, and later in the this inflammation or disease, whatever it is, spreads into the parietal area in front. So present parietal is actually somatic. This is visceral is only parasympathetic or sympathetic. So pain will be very different. So parietal pain is severe actually once it involves later. So that's why this classification is important. To identify this is also important. Type of pain differs in visceral and parietal. So you have to ask that specifically. So intermittent and progressive pain appears, then subsides. Pain appears, subsides. Ureteric stone, gallstone, intestinal colic, biliary colic. Whereas progressive persistent pain, burst appendicitis, gangrenous bowel, ischemic pain, pancreatitis, they are progressive and continuous. So these classifications of pain, and by history to identify these things are very, very important. Remember, so again, these classifications are quite significant. So ask the patient to find out where is the pain is. That is called pointing test. That's very, very important. You ask the patient, where is the pain? They'll show pain is here, pain is here, pain is here, like that. So that gives a gross idea about where exactly probably pathology, because where pathology, pain begins where the pathology is there. Then eventually spreads all over. So where it started, the patient knows. So ask him, then he will show that where exactly it is. That will give you a fair idea about what exactly is the problem. And change in the position of pain or spread of pain, shifting of pain or migration of pain, I'm not going to detail it. You know that in acute appendicitis, pain initially appears around the umbilicus, then later shift to the right left fossa, because initially it is the same segment pain in the umbilicus. Eventually, because inflammation spreads and goes to the parietal peritoneum in the actual position of the appendix. So initially it is the visceral segmental pain. Eventually it is the local pain, parietal pain, visceral pain, parietal pain. So that shifting of the pain migration very typical in appendicitis. Also seen in duodenal ulcer perforation. Initially in the epigastrium, we know that duodenum is in the upper abdomen, but once it gives off, then content comes out of it, trickles over the lateral paracolic gutter, and pain comes down, migrates into the lower abdomen, into the right left fossa. So spilling over the right paracolic gutter sometimes mimics appendicitis, perforated duodenal ulcer. Many times it happens. You think even sonology, they say it is appendicitis. You open, then appendix is normal. Then you see, when you do laparoscopy especially, it is advantage laparoscopy. You see that they are perforated duodenal ulcer. So that is a important thing. Many times you miss and you may lose the patient. You thinking that you remove appendix, but actually you are missing the duodenal perforation. That is not uncommon to happen. There is a point which you have to always remember. Referred pain, this is little different, where it is same segmental cutaneous distribution of the nerve. Visceral part is sympathetic supply segment, whereas the cutaneous part is somatic. So examples are diaphragmatic irritation causes the pain in the right shoulder, and splenic irritation causes the pain in the left shoulder. All these things are the referred pain. Another example is all these junctions, whatever that segmental areas, umbilical area to referring down, iritic stone referring down along the testis and the inguinal region. So all these things are the very typical of the referred pain. It differs from the shifting of the pain. It differs from the radiation of the pain. Radiation is the pain present at the region, also present where it goes. Whereas referred pain initially present in one place, then eventually shift to other place. So that is the difference between the referred pain and radiation of the pain. So gallstone going to the inferior angle of the scapula. Pleuritis, pneumothorax causes the referred pain to the abdominal wall, mimicking acute abdomen. Already told, these are the conditions which you have to remember. You may miss pleuritis, pneumonia, and so on. And radiation of the pain is very typical is the pancreatitis. Patient will have pain in the epigastric region and it radiates to the back. This way patient leans forward like this so that to get relieved of the pain. So certain extent it will be helpful to the patient. So that is the typical. Pain will be there in the epigastrium, also back, because of the nerve which is basically pancreas is in the retroperitoneal region. It contains a lot of parasympathetic nerves actually, splanchnic nerves it is called. And these nerves gets irritated, so they will have pain in the back. Very typical. So both here and back, very severe pain, intolerable pain in this. This is the typical radiation of the pain. In duodenal ulcer perforation, when it penetrates posteriorly also they will have back pain. So main typical example is pancreatitis for radiation of the pain. Somebody has given an example of radiation of pain. First thing I will tell is the acute pancreatitis. That is the correct example for radiation of the typical pancreatitis patient leaning forward and trying to reduce his pain actually. So aggravating and relieving factors, there are so many aggravating relief factors. After omitting, pain relieves. After taking some medicine, pain relieves. After passing the stool, pain relieves. So these are the different things. Pain aggravates by coughing, sneezing. Pain aggravates by changing the position, moving the forward. These are the different ways of the acute abdomen. Pain aggravates by moving, but just quiet, silent, you keep quiet, then pain will get relieved or reduces. So these are the different things you have to remember. In gastric ulcer, pain aggravates after taking the food. In duodenal ulcer, pain is relieved after taking the food. So there is some relation. What are the factors which aggravate pain, reduces pain? So if you know these things, then you will have the idea. You know, they have already shown the photo. When you lean forward, pancreatitis pain will get relieved. So these were different aggravating relief factors for different conditions are there. You should know these things. So other symptoms, I am not going to detail, vomiting, jaundice, fever, constipation, urinary symptoms, gynec symptoms in females. You have to always specifically ask last menstrual period, and you have to ask regularity, and you have to ask number of pregnancies, delivery, type of delivery, all those things are important. Previous surgery is very important. Earlier trauma also important, which many times We tend to forget tasks which may be very, very relevant in specific situations. And examination is important. Shock features, pulse rate, tachypnea, fever, sweating, cold fever. It's the features of shock, hypotension. All these are the features of shock. In acute abdomen, shock is very specific. So based on then, of course, distension, discoloration, tenderness, rebound tenderness, mass, hernial site, all those things you have to examine. Examine fully. You can see the distension here, dilated probably sigmoid volus, colon looks like dilated. Again distension here, probably peritonitis. You can see the dilated bowel here, intestinal obstruction. You can see the bowel here dilated. And if you see the live patient, you may see the peristalsis also. So inspect properly from side, from foot end for distension, inspect the hernial orifices, inspect the thorax, inspect the movement of the respiration, examine properly. Then you will have the idea what is the probably cause for the current problem based on the history. So you can see that not uncommon intestinal obstruction, hernia causing intestinal obstruction is not uncommon. Remember, if you don't expose this area, then you will miss the actual cause, which is hernia causing the obstruction. That's why examine properly, examine groin area and scrotum. And see, look for the rebound tenderness. See that, look at the eye of the patient. It's wincing like this, because when you touch, he winces like this. So severe pain. So that's important sign, rebound tenderness. The other is called the Blumgard sign. So percussion is important. Check, always start with the liver dullness. Abdomen percussion is very, very essential. It says anatomical plane of the disease. First, always start with the liver dullness, because the baseline, it gives a guideline. So liver dullness is normally in the right side, fifth intercostal space in the midclavicular line. It is obliterated in all perforation. There are certain exceptions. I am not discussing about that. Duodenal ulcer perforation, gastric ulcer perforation, ileal perforation, traumatic perforation, or colonic perforation, or malignancy perforation. There are different causes. But obliteration is very, very crucial, very important. So the liver dullness always should be checked. Then check the abdomen, always percuss the abdomen from the umbilicus, then go laterally. Umbilicus till central abdomen, when there is a distension, will be tympanic, high resonant, and dullness will be there in the flank if there is a fluid. So if there is a fluid, always check for the shifting dullness. All of you know how to check for lifting dullness. It's a clinical method. And shift the liver dullness, site of, and whether it disappeared or not, all these things. So all these examinations are there in my clinical methods in surgery with the video lecture there. And also we can go through my earlier SRB's Surgical Insight YouTube, where these examination methods, small lectures are there clearly mentioned. I have discussed these things. You can always go through those lectures. My manual clinical method also, it is very clearly mentioned, all these examination. You can go through that for the detailed understanding of that. Auscultation is very important. So whether bowel sounds are absent, high pitched, or increased, or metallic, or vascular bruit is there, auscultation is usually done around the umbilicus in lying down position. For renal bruit, you have to check in front and behind also, both sides. So auscultation also again important. And now important thing is digital rectal examination. That is very, very important, otherwise called as PR, per rectal examination. If you don't do that, so many things may be missed. So in acute abdomen, you will be able to see dilated rectum, empty rectum, dilated rectum. You can feel a tenderness wherever you may see a boggy swelling over the in front. In a regular, even though not acute abdomen with the abdomen mass, we will be able to feel Bloomer shelf, rectovesical secondaries. It is a hard, nodular, shelf-like feeling in the rectovesical fossa, where mucosa of the rectum is normal, but it's in the deeper plane. It suggests always there is peritoneal secondary of whatever the malignancy disease in the abdomen. That means it is almost T4 or stage 4 lesion. So it's advanced disease. So Bloomer shelf, boggy swelling in the pelvic abscess, tenderness in different areas, empty rectum, ballooning of the rectum, dilated rectum is called as typically clinically ballooning of the rectum. All these things has to be done. Sphincter tone has to be assessed. So any mass lesions, any ulcers are there, you'll be able to feel. So many things can be assessed. Sometimes you may do a bimanual palpation, one finger inside and hand above, and try to feel any masses there. So that is also possible with the digital rectal examination. So very, very important examination required for all abdomen examination. Without a digital rectal examination, your clinical examination is incomplete. Remember, always you should know how to do that, what are the different positions and what are the points which you look for, and how will you interpret these different findings. Even prostate enlargement is assessed by digital rectal examination. So you can always read my clinical methods in surgery. Digital rectal examination is there with the video showing how to do that. You can understand that one in a better way, but it's very important. So these are the basic things you have to look for: tenderness, empty rectum, boggy swelling, ballooning, of course in malignancy, Bloomer shelf. So these are the different things you have to put it in nutshell. This slide is very important. Feature shift shock, I already told. Local features, I already discussed it. I'm putting in the table. Percussion, again, is important. Auscultation. So the table is very, very crucial and important for all students to understand what are the things you look for while examining a patient with the Pandora's box or acute abdomen, whatever you call it. And I'm just going through these slides. I'm not detailing it because it's a very vast topic. Individual topics will have lectures eventually. So acute peritonitis, all these things are important. Pus will be there, acute abdomen will be there, distension will be there, tenderness, rebound tenderness, dull flank. If there is a perforation, obliteration of the liver dullness, then PR may be able to do empty, this one, and tenderness. So these are the different causes: pancreatitis, biliary cause, perforation, GA cause, appendicitis, gangrene, mesenteric ischemia. So many causes are there. I'm not discussing about these things. Just it's the most important thing in the acute abdomen, remember. So what are the different pathologies here? All these things are, whatever the diagram, which is so many things are there. You can always go through that. You can see sigmoid volus, splenic ischemia, gangrenous suppurative gangrene, and acute pancreatitis, perforated gastric ulcer, perforated duodenal ulcer, and acute appendicitis, mesenteric Meckel's diverticulum, diverticulitis, ischemia, torsion, ovary, ruptured ectopic here, everything. This diagram given all acute conditions usually present like. So if you will picture as this diagram, you'll be able to have a clear idea about the different causes of the acute abdomen or Pandora's box as such. So acute abdomen is a very common entity, all of you know, very often may not be identified by even ultrasound and CT scan. It's basically a clinical diagnosis, rather by confirmation, often by method of ruling out. So rule out other conditions, mainly uritic stone, in female ovarian pathology, ectopic pregnancy, and mesenteric adenitis, and gastroenteritis. So these are the differential diagnosis for acute appendicitis. So rule out these conditions clinically, come into conclusion that is acute appendicitis. We have seen even by sonology they will miss it, even by CT scan they will miss it, even by MRI sometimes they will miss it. It's your clinical intuition which gives a perfect diagnosis, and go ahead with the laparoscopy. Laparoscopic appendicitis is the ideal approach, currently not open. If laparoscopy will find difficult, then only convert into open appendicectomy. So ideal treatment strategy for all appendicitis currently is laparoscopic appendicectomy. So this is exactly the laparoscopy, pus is there, the burst appendix. So appendicectomy is done through the laparoscopy. And all these things are Sharon's triangle, hyperesthetic area. Note the McBurney's point here, appendicitis. The burst appendix again, the suppuration there. So I'm not going to detail it. You can read my book, SRB's Manual of Surgery for acute appendicitis topic, even clearly with a lot of photos, illustrations, and management policies. And perforated duodenal ulcer, again, it's very important. You have to close the perforation. Tenderness, gas under diaphragm is very, very typical. See that? Kupolo sign, diaphragm is here. This is the diaphragm. And you have a lot of, this is the liver, this is the gas. So this gas is, gas under diaphragm is very important. This is X-ray chest with the upper abdomen in erect posture. It's not just X-ray abdomen. It's the X-ray, chest X-ray with the upper abdomen in erect posture, in standing posture, where gas comes up between the diaphragm and upper part of the liver and forms a typical air shadow. So that is the typical diagnostic X-ray. Of course, CT is the currently plain CT is the confirmation. Plain CT is 100% clear, surely shows that there is perforation. Maybe duodenal ulcer perforation. Maybe whatever the differential diagnosis, but commonly it's the duodenal ulcer perforation. It is the anterior It is the anterior duodenal ulcer perforates, not posterior, because it is towards the preperitoneal cavity. Posterior usually penetrates or bleeds. Anterior perforates, posterior bleeds. That dialogue you have to remember, and you have to immediately open the abdomen and suture the perforation with the 3 sutures, either silk or vicryl. Then give a very good peritoneal wash with the warm saline. Then place a drain. That's how exactly we'll manage. Pancreatitis usually treated by conservative method: serum calcium, serum amylase, serum lipase, and CRP, and blood count has to be done, and CT imaging has to be done, graded Balthazar grading has to be done, then treated accordingly. And you may have to do a CT guided aspiration to confirm whether infection is there or not, necrotic or not. Then accordingly you start antibiotic or treat accordingly. You have to admit and treat. It's a very severe pain will be there. GI bleed is a very challenging one, maybe upper GI bleed that is proximal to the ligamentum trees. Lower GI is below the ligament trees, small bowel and large bowel. Both upper GI and lower GI is very, very difficult to manage. It's a very big topic, needs endoscopy, gastroscopy, colonoscopy, CT angiogram, and angiographic embolization, sometimes surgery, lot of blood transfusion, FFP, platelet transfusions, and outcome sometimes very difficult to predict in these patients. And rather very challenging emergency situation is GI bleed, both upper GI bleed and lower GI bleed, demarcated by ligament of treads. So intussusception, common in children, adult also. In children it is benign entity. It's the telescoping of the proximal bowel loop into the distal bowel loop. Commonly ileocolic, maybe ileoileal, ileocolocolic, colocolic, and different types. In children, initially therapeutic reduction is done if patient comes early within 6 hours. In adult, usually there is a tumor, benign or malignant. Treatment is surgical. Reduce it and do a resection anastomosis. Barium study, X-ray is a claw sign. Usually CT is diagnostic with the pseudo kidney sign, or so many signs are there. Even ultrasound is very useful. Think of malignancy in adult. That is the point which is removed. Most of the time they need resection and anastomosis. That is the point. Intussusception definition is important. Usually it is antegrowth, telescoping of the one segment of the bowel to the adjacent segment. That is the proper definition. You can read my manual of surgery. It gives a detail about the intussusception, and it's a common theory question also in the exam. It presents as a mass, saucer shaped mass appears, mass disappears around the umbilicus mass with the concavity toward the umbilicus, like that. All those features are there. Please go through my manual of surgery, this topic, one in detail with the proper photos. Sigmoid volvulus, again acute condition, twisting of the sigmoid colon along the axis, usually anti-clockwise, more than 1.5 times has to twist to cause the gangrene, and tympanic abdomen, dilated abdomen, fecal into vomiting, distension, toxicity, absolute constipation are the typical features. And X-ray is very diagnostic with omega sign or beam sign, and CT is again diagnostic, plain CT. Treatment is initially, and in OT you can do a therapeutic passage of the flatus tube. Otherwise, on table you have to retwist the root to the bowel and fix the bowel, fix the sigmoid colon, called as sigmoidopexy. If it is not viable, then you have to do a sigmoid resection. Then distal mucus fistula, proximal stroma, because in acute condition we can't do anastomosis because don't take up, risk is there. Always do a stroma, that is called Paul McCulloch's operation. So read my book again for this condition. So mesenteric thrombosis, again ischemic condition, thrombosis, embolism, atherosclerosis, all those things are the causes. Again, large segment of the bowel is ignored, they go for a resection anastomosis. Short gut syndrome is one of the things which we will face in this patient. Again, we can always go through my book to manage these patients. So mechanical intestinal obstruction, this is what exactly happens. Crampy pain, obstipation, distension, vomiting. So these are the typical 4 features, 1, 2, 3, 4. And this diagram shows how exactly it happens. I'm not going to detail it. You can always go through this diagram. It's a very clear picturized view of the pathophysiology of the intestinal obstruction. And obstetric gynecologic causes are quite common in females. Remember, think of this condition: ectopic gestation, abdominal pregnancy, rupture uterus, molar pregnancy, ruptured ovarian cyst, ovarian torsion, ruptured abscess, perforated. So the different conditions we have to remember. Extrapedural causes are again important, remember, not from the abdomen, present as abdomen pain, but not from the abdomen. What are they? Cardiothoracic, pericarditis can cause, MI can cause, respiratory thing, pneumonia can cause, pneumonitis can cause, some effusions can cause. So remember these things. Urological causes, pyelonephritis, stones, vascular causes, which aortic aneurysm can cause, and other causes like porphyria and so on. So remember these causes, especially in the abdomen pain, that extrapedural causes mimic abdomen condition and will misguide you. So it's very important to remember these conditions, and so that it may be something else other than abdominal pain. So Pandora's box, this is what ladies open in the box and looking for that. Then all levels has come out. So these are the Pandora's box in the abdomen compared to these two things. See that? This is the entire thing, all quadrant of the abdomen. Right upper quadrant, epigastric quadrant, left upper quadrant, central quadrant, and right lateral fossa, suprapubic region, and lateral fossa. All conditions you have to think of in a Pandora's box, otherwise you will miss. That's how it is compared, remember. And signs of intraabdominal sepsis, I'm not going to detail it. Fever, toxicity, tachycardia, tachypnea, abdominal pain, peritoneal signs, guarding, rigidity, tenderness, free fluid. Signs of dehydration, tachycardia, hypotension, leukocytosis, blood, shock, multiple organ failure, morbidity and mortality, obstruction, fluid imbalance, perforated viscous peritonitis, infection, sepsis, shock, fluid imbalance, peritonitis, sepsis, shock, hypovolemia, ischemia upon peritonitis, again, ischemia. All these things are the entire thing. It gives a very clear idea about what happens eventually if it is not treated properly. Death ensues. You have to operate. Without surgery, patient is going to die 100% in many acute conditions, especially perforations, gangrene, and ischemias. Remember, surgery is a must. Surgery is the only choice in such situations. So remember, GA malignancy can present as acute abdomen often, especially colonic malignancy, small bowel malignancy, they present with obstruction. Observe small thing and everything is small thing. That is important in the abdomen. If you don't observe, you will miss the bus, miss the condition totally. So that is very important. Observation is most important in abdomen, remember. So how to manage these patients? Plain X-ray abdomen and chest erect. Chest is important, not just plain X-ray abdomen. Chest X-ray with the upper abdomen. That is important. The chest is very important. Without chest word, your answer is wrong. CT abdomen, pancreatic obstruction, especially to look for gas under diaphragm. This is important. Serum electrolytes, amylase, lipase, blood parameters, renal function test, LFT, other essential things depending on the situations. And see that obstruction is typical obstruction. Again obstruction, valvulae conventis. This is the house situations, colon. This is the colon. House situations are there. This is a small bowel. This is called as valvulae conventis. Valvulae conventis, very typical. So of the small bowel obstruction, this is there in my book, Manual of Surgery, and intestinal obstruction topic. All these are given in detail. You can go through that. CT is essential currently. CT is currently done diagnostic investigation. You can see the gas under diaphragm here. This is the diaphragm, the gas. This is the gas under diaphragm. Mainly the right side is more important. Chest with the erect abdomen, erect posture. That's important. See that dilated bowel with the fluid. See the dilated colon so much. So this dilatation is very typical. Sigmoid wall. See that dilated colon. Very typical. This is the small bowel dilatation. So very typical. It's look itself gives the diagnosis. Very typical feature in the CT. So CT is the most important investigation for all these acute conditions. Remember. So rise tube you have to pass a catheter, ICU care is required, lot of IV fluid, sometimes central line. Then antibiotic has to be started. Basic evaluation like ECG, echo, chest X-ray, physician fitness should be done very quickly because you need to take up the patient for surgery, especially in perforation and intestinal obstruction. fluid management, essential blood and blood products has to be arranged, and general antibiotics has to be started in this patient. You can't wait for the pus culture to come because sepsis is there. And role of surgery, remember all acute abdomen do not require surgery. Pancreatitis do not require surgery. Pyelonephritis do not require surgery. Some enteritis, diverticulitis do not require surgery. But perforation, gangrene, ischemia, obstructed hernia, burst appendix, all these require surgery. Surgery as early possible. You can't say tomorrow or after tomorrow I will do. Do it immediately. Any delay in time worsens the situation, delays the recovery and increases the morbidity and mortality. That is the point. Do it as early as possible, not tomorrow, today and today itself. But when surgery is essential, earlier surgery is the better, I already told, save life and prevent complications in peritonitis. When surgery is required, do surgery as early as possible in acute surgical condition. That is the point which you have to remember. Don't delay because you are busy. Do it as early as possible. Complications, high risk, 50% mortality, late presentation worsen the situation. So golden period is very, very important. As early as possible. I already told. Septicemia, fistula, respiratory failure, burst abdomen, all these things are the eventual complication. Burst abdomen, interstitial hernia, it's a sequel actually. Eventually you have to treat it as and when required because patient general condition will be poor, patient will have a sepsis, patient will have a nutritional problem, patient will be in shock. So naturally, interstitial hernia, burst abdomen, delayed recovery will be there. You give a supportive treatment, TPN, albumin, blood products, then make them all right in due course of time. That is a point which is very important. Approach to abdomen, that is approach to Pandora's box. That is how exactly we'll approach all these abdomen. Now I am not telling only acute abdomen, any abdomen. Abdomen itself is a Pandora's box. So how you will approach? So acute abdomen, I have just given one of the Pandora's box, the acute abdomen. Another abdomen which is same. History is important, already told. Symptoms and signs important. Clinician surgeon perception is important. Clinician surgeon description is important. See, for your perception is important, not the imaging. You are the one who is going to treat the patient. So as a surgeon, you should take a call, you should take a decision, you should have a perception, you should have a description, you should have an interpretation. Perception, description, interpretation. That is a very three essential thing for a surgeon to manage such patient. Remember, you listen to yourself, not to others. That is the point which is very important. Laboratory findings, imaging, X-ray, CT, ABCD in a shock. I am not going to detail it, all of you know that. Final diagnosis, and this is the most important eventually. So all these things are the supportive thing. And finally, your management policy, decision making, is very, very important in any abdomen, any Pandora's box condition. So again, another chart, I am not going to obstruction, fluid management, perforation, shock, infection, sepsis, bleeding, hypovolemia, ischemia, perforation, peritoneal shock, systemic inflammatory response syndrome, multi-organ dysfunction syndrome, eventually death. Like this, like this, like this. So problems, any abdomen for that matter, any major surgery in the abdomen for that matter. This is what exactly may happen. You should be aware of these things to prevent and finally avoid death, avoid problem, make a sure safe eventual outcome. That is the important thing which you have to remember as a surgeon. So remember, all acute abdomen should be assessed clinically by repetitive exam. This is the point which is important. You see the patient, admit and go, not you examine again, go in the ward, see patient again and again. It's important. Imaging may be negative, remember, in all these patients. Don't rely on imaging. Rely on your imagination. Already told. Perception, description, interpretation, imagination. That is the four things very essential when you treat such patient as a surgeon. Acute pancreatitis, highly treated non-surgical. Remember the condition which you treat non-surgically. Don't unnecessarily put your knife. Missing surgical in acute abdomen means 100%. If there is a perforation, if you don't operate, they will die 100%. So you should be aware of that. It's very, very important. Do surgery early when it is needed. So abdomen makes surgeon as a hero and villain both. You are the both sides of a coin. If patient becomes all right, you are a hero, like Amitabh Bachchan. If patient not all right, patient dies, people make you a villain, like Amrish Puri or something else. I'm not telling the name. Be ready to be a villain or be ready to be a hero. There is a point I am telling you, because you should able to accept both sides of the coin in your professional surgical career. That's the point which is important. Acute or elective abdomen is often most complicated but correctable. Remember, a Pandora's box. See that? It is very difficult to manage. Nothing is seen there in spite of all these things. That is the important thing, but it's correctable. You treat it, correct it, inside, go inside to that, then you will have the idea. So evil and hope, Pandora's box, abdomen is having both evil and hope. It is when there is a disease, it is evil, but you should have hope. That is exactly Pandora's box. Evil and hope is a Pandora's box. That is abdomen. Why diagnosis? All the things are important. Delayed presentation, history may not be adequate, atypical presentation, peritoneous features are masked. There may not be peritoneous features, especially typhoid perforation. In severe sepsis, guarding will not be there. You may miss it. In partial obstruction, Richter's hernia or partial obstruction, they will have diarrhea. You think it is the GA condition, it is the medical condition. You may miss surgical condition and may lose the patient. So in spite of so many new investigations at our disposal, like ultrasound, CT, MRI, the human belly defeats them all and reveals its secret only when confronted by a surgeon's scalpel. Finally, when you open the abdomen, you will be able to say what exactly it is. That is the final verdict, it is the final judgment. So your scalpel will tell the truth, who is correct, who is not correct. So until then, abdomen is a big mystery, it's a big magic box. It is a Pandora's box for all surgeons, remember. So surgery never runs out of suspectful surprises. Last operation that a surgeon performs on the abdomen before returning might be seen, may not seen until then. That's the point. That's the point you have to remember. Remember, even post-laparotomy and complication arises and recovery delays, it becomes second Pandora's box. You have done a surgery and after that patient comes back with some other problem or same problem with some complication, then again it becomes Pandora's box. You won't be knowing what complication inside. Again, it is a dangerous thing. So second Pandora's box is possible. After treating also, it may complication also, we won't be able to diagnose the complication. There is a more problem. It is called a second Pandora's box. Remember the story of Pandora's box. Negative laparotomy, known entity, remember. But better to err on the wrong side. It doesn't matter if you need not be right, but never be wrong. There is a very important dialogue which you have to remember. And no shortcuts to detailed history and examination. Decide whether it is a surgical abdomen. Serial assessment clinically, finally it is a clinical assessment. I'm repeatedly telling, serial assessment clinical is very, very important, remember. At the end of all this, decide whether it is abdomen with a surgical cause or not. Not necessary to make an exact diagnosis, though we should be aware of the possibilities. So aware of all possibilities. Think, analyze, interpret. These are the three things which is very, very important. Rule out pancreatitis in all acute upper abdomen. Rule out perforation in all acute abdomen. Rule out cause of outside the abdomen. Think outside the box. That's important. Extra abdominal causes I already discussed. Exploratory laparotomy still exists as abdomen is still a Pandora. In spite of all these things, you may have to explore the abdomen, see what exactly is the cause. That is the point which is remember. So still what is an entity called exploratory laparotomy exists, remember. And students, please subscribe my YouTube channel and share with your friends and colleagues and press the bell and go through my YouTube channel. A lot of brief lectures are there and go through that so that daily, day-to-day basis you can learn surgery. And also now MCQs are coming daily. Please read this MCQ, put right answer, then eventual right answer, your answer will be appreciated. And also right answer will be put in 24 hours. And once a week we'll have a long lectures of different parts of the surgery. And live sessions once in 2 to 3 weeks we'll have, where undergraduate will present a case where you can join the live session and interact through chat box. And many senior professors will join this one and have a good interesting discussion for more than 1.5 hours. And it's a learning for how to present a case in the exam. So you'll learn how to present a case, how to discuss the case, so practical exam, how to face, all these things will be learned. So please join live sessions whenever it is arranged. And also, if you join live session, you'll get a certificate which will be very useful for your future career. Again, request again students subscribe my YouTube, which is free. Learn surgery on daily, day-to-day basis. Also, I'll request you to have my clinical methods in surgery book and surgical manual, SRB manual of surgery. And if you have this book with my website, you can learn surgery entirely without any problem. My clinical method surgery current edition has got each chapter. It covers everything from general surgery, hernia, hydrocele, then vascular disease, venous disease, then GI entirely, urology, specialty, briefly orthopedic, with a lot of photos, illustrations, with each how to examine a patient for each topic. Suppose hernia, how to examine a patient with a QR code lectures for 20 minutes, video how to examine. Same thing for varicose vein, arterial disease, swelling, ulcer, everything. But there is no management component in the clinical methods. But very, very useful to face the exam and answer your exam questions. And how to examine a patient is very useful. My manual of surgery covers everything as for CBM syllabus, general surgery to specialty to GI, endocrine, which contains instruments, anesthesia, everything with the footnotes, quotations, management policies, lot of illustrations, photos, descriptions, analysis, everything. So have my SRB's manual of surgery. It is complete book for students, undergraduates, postgraduates, all beginners, learners, and also have my clinical methods in surgery. Of course, purchase my DigiNow lectures through JP Publishers. Around 220 lectures are there, which covers everything as far as CBM syllabus, including examinations. For 1 year, you can purchase through JP Publishers with the learning process of entire surgery properly without any confusion. So students, I hope you have understood this lecture. Abdomen, a Pandora's box. Very well. Thank you so much.